Good afternoon, good morning, everyone. Welcome to Sunstar webinar series for professionals entitled Let's Talk Oral Health. My name is Rachel, and I will be your host today for this sixth and last webinar of this year. First, a logistic point. If you are watching us through the registration platform Eventbrite, you may want to switch to YouTube by following the link at the bottom of your screen in order to enjoy the full screen mode, but also use the chat box to ask your questions. Your questions will be conveyed to our speakers during the conversation whenever possible or at the end of it. The series of webinars this year tackles home-based oral care within various dental disciplines. We already had webinars on the challenges and solutions for home-based oral care in periodontology, orthodontics, pediatric dentistry, and special need patients. Today, we will focus on implantology and specifically what can the oral health professionals do in order to support the patient when implants are considered, already in place, or already affected by a disease. To do so, we are very happy to welcome two renowned speakers today. First, let me introduce to you our first speaker, Professor Anne-Marie Roos-Jansåker.
Hi there.
Hello, Anne-Marie. How are you?
I'm fine.
I'm fine.
I have a little coughing risk, but I'm fine. Looking forward to this.
Thank you for having accepted our invitation to this webinar. Let me introduce you to our audience then. Anne-Marie, you are an associate professor in Malmö University in Sweden. You are the past president of the Swedish Society of Periodontology and Implantology, and your research has always evolved around periodontitis and peri-implant diseases. To talk about this topic with you today, you will be joined by Miss Susan Wingrove. Hello, Susan. Good morning to you, as I believe it is early morning in the US.
It is.
So happy that you are with us as well. So let me introduce you likewise to our audience. So Susan, you are a dental hygienist, but also an international speaker, author, researcher, and instrument designer all about protocols and treatments around periodontal diseases and peri-implant diseases as well. So we are very happy to have both of you on this virtual stage today and are eager to hear from you. So let's start directly the conversation. May I ask you, Anne-Marie, to set the tone, set the stage, and introduce the topic to us with some disease and case definitions for the implant?
Yes, I will be happy to do that. Well, we have new definitions that were presented at the World Workshop on classification of periodontal and peri-implant diseases and conditions in 2017, and that were published in 2018 and 2019. And there is a difference between disease definition, that is description of a condition, and case definition, that is a number of criteria that help the clinician to set the diagnosis. So what you see here is peri-implant health, and that is as healthy mucosa. There should be absence of clinical signs of inflammation. That means no redness, no swelling, and of course, no absence of bleeding on dental probing. And this is what you see on this clinical picture, a firm mucosa, and when I probe, there is shallow pockets and no bleeding on probing. On the radiograph, there is absence of bone loss beyond initial crestal bone remodeling. However, it is important to know that a healthy peri-implant pocket can be 4 millimeter or even deeper. So you can't compare the pocket depth around an implant to a pocket around a tooth. This depends, of course, of how deep you have inserted the implant and also the thickness of the mucosa. But remember that pockets that are 5 millimeter or deeper can be a risk for pathological microbiota to grow. If we then go to peri-implant mucositis, the disease definition is that peri-implant mucositis is an inflammatory lesion of the soft tissue surrounding an endosseous implant in the absence of loss of supporting bone or continuing marginal bone loss. And the case definition is clinical signs of inflammation, bleeding and/or suppuration on gentle probing, and no further bone loss after initial healing. And this can be the fact in both shallow and deeper pockets. And as you see at the clinical picture here, there are bleeding after gentle probing at the distal buccal site of the implant restoration. But on the radiograph, there are stable bone level. The etiology of peri-implant mucositis is the biofilm. And if biofilm is allowed to accumulate after the reconstruction is placed, there could be inflammation and in the suprastructural tissues. If we then go to peri-implantitis, the disease definition is that peri-implantitis is a pathological condition occurring in tissues around dental implants, characterized by inflammation in the peri-implant connective tissue and progressive loss of supporting bone. And as you see here at the clinical picture, there are redness, erythema, and swelling of the mucosa. There are bleeding and suppuration on gentle probing, and there are increased pocket depths of 6 to 9 millimeter in this patient. And on the radiograph, you see radiographic bone loss beyond what you could expect after initial remodeling. So the etiology is also here the biofilm, and there is today no evidence at all that there should exist no plaque induced peri-implantitis. So we can go to the next slide, Rachel. Yes. So could peri-implantitis be a threat to reimplant? Yes, it could. Of course, if we don't diagnose early signs of peri-implant disease and start treatment early, we, of course, can lose all the osseointegration and the implant will be lost. And I recommend that we divide peri-implantitis into mild, moderate, or severe, depending, of course, how long the implant is. But mild peri-implantitis could be treated with a non-surgical approach. However, moderate peri-implantitis may be considered for a surgical approach. And then, of course, severe peri-implantitis, as you see here on the right, an implant like that should be considered to be removed. Most implant cases, the onset of peri-implantitis start early and have a non-linear progression. And to compare peri-implantitis with periodontitis, it's important to know that peri-implantitis is more aggressive, and the lesions with the inflammatory infiltrate is larger than compared to periodontitis. So that's why, Susan, it's very important to assess the peri-implant tissues.
Yes, I agree. And I think looking at this slide, if I might make a point here, for especially for hygienists and dentists to look at their radiographs and to do a measurement with a probe, simple to do, put the probe up there, measure the length of the implant, or know the length of the implant based on information they have. It's a 10 millimeter, 9 millimeter implant. And then Dr. Fromm put together a kind of a nice segue for us to be able to determine whether it's mild, moderate, or severe, based on, and this would be for a lot for hygienists, in that we want to measure, and 25% or less bone loss on the radiograph in comparison to the length of the implant. So this is in comparison to the length of the implant. The 25% or less bone loss would be mild. 25 to 50% bone loss would be moderate, and over 50% would be severe. And of course, these are 2D films, so 3D films show things differently, but I might add that and then go through an assessment slide with you. On this assessment slide, we've had a lot of years now that we have done this assessment and had very good success with it. And it doesn't add a lot to your regular clinical time either. You typically do a visual tissue assessment. So that's something that you always, of course, want to do around implants as well. It is now important to have, we'd like to have keratinized tissue around all of our implants. So we look to see how we can do that. And there's some home tools we can use to do that with that we're going to get into later. Probing and palpating, and we always get questions about probing. You can probe with a stainless steel, plastic, or titanium probe. And for sure, you want to wait at least 6 months post-load to measure an implant with a probe for probing depths. But ideally, you'd wait 1 year post-load when the restoration has been fit on the implant at 1 year to get your true crustal bone remodeling at that time and get a more accurate probe reading, and then check those probe depths. But it has to be the same person doing it. Check that probe depth each time you see that patient. I know you can record any bleeding on probing as well. And the bleeding on probing is difficult to see sometimes around implants. And Dr. Renneberg has put together in the latest classifications, he's put together that we would do either 0 for healthy and 1 for inflammation. So you'd want to record that. And palpating is really important because I think that tells us the health of the implant. And that one is, we want to see if there's any infection in the implant. We want to squeeze on both sides of the ridge up to the restoration or down to the restoration on the upper. And palpating will show if there's any bleeding or exudate, better than bleeding on probing even. So always palpate implants that you have at any time to see if there's any inflammation present around the implant. If inflammation is present, we know that the cascade can happen and tissue loss and then bone loss. So we don't want that to happen around the implant. And then assessing for calculus and cement, not all implants will need to have instrumentation around them. Mostly will need biofilm removal, which is our major risk factor. But if you assess the implant with floss, because it's around in a circular manner, putting it on the mesial, the distal, crisscrossing in front, shoe shining, and then taking it out on the mesial and taking it out on the distal is a safe way to floss. Don't pull it through. And check and see if there's any blood on the floss. Implants don't bleed, so if there is blood on the floss, the inflammation cascade is present in there at that area, and we need to find out why. We then would pick up an instrument and we would use instrumentation around the implant with proper instruments. They need to, according to the latest research and everything, be titanium implant scalers only, or PEEK, PEI, or titanium ultrasonic instrumentation. And then assess for mobility and occlusion. And the doctor would check occlusion at the time of the exam. This is important. I think Now that we're seeing more implants, even a single implant in all of our patients, we should start checking occlusion at each and every maintenance visit, because that way we will always be monitoring the occlusion on any implants that are present on the patient. And so get in the habit of having your hygienist have that paper and check for you as a doctor would check at the time of the hygiene exam. And then the most important thing is the bone level. And the bone level on implants, 1 to 4 implants, take your vertical bite wings or your PA implant x-rays at least once a year to assess for the bone loss. That's going to really tell us the health of the implant. 5 or more, you'll want a CBCT or a Panorex on those patients, or individual PAs are also possible for that. If you see unexplained inflammation or radiographic evidence of bone loss, then you should refer to have a peri-implantitis evaluation done and a 3D scan for the patient. So if you switch to the next slide, Rachel. This is an important slide, and I mostly wanted this in there. It's a lot of words on there, but I wanted it as a resource for you to look at later, that you will receive this. And you'll have a resource to look at. And this is based on the 2017 World Workshop that took place on periodontal and peri-implant disease. And very, very much based on the Berglund and Armitage papers that specifically go into peri-implantitis. And I just like to kind of walk through a little bit of this with you. Anne-Marie has already gone through the definitions, so I won't spend too much time on that, but I want to go through and at least verify that if you looked at this chart when you're using it as a resource later, you'll see the different categories are listed here: healthy, mucositis, peri-implantitis, and peri-implantitis. And this is a patient that's come to you with no previous examination, but they already have implants in their mouth. So there's no radiographs and things. So you need to start as a new patient, and they're coming to you with implants already placed in their mouth. So if we just start on the healthy implant, when you are looking at this just gives you a good idea of inflammation, you know, and these are the categories that Anne-Marie was talking about on the definitions. And then if you see the third column, this would be something that you would put in your patient record notes. I like to add that for clinicians, so you know what you should really identify and have in your patient records, that there is no bone loss, you know, no inflammation for a healthy implant. And I also put the recare amounts in there as well. And seeing these patients at least every 6 months is the new research, and guidelines for that is at least every 6 months for any implant patient. And then your mucositis patient, of course, once they have inflammation around the implant, they would be categorized as a mucositis patient. Some bleeding on probing, possibly. Also, it's good to record a gingival index of whether you see mild, moderate, or severe inflammation as well at that time. And you notice that their recare would then be at least every 3 months. And then peri-implantitis, and I talked about it a little bit with this in your records. You would put down whether it was early, moderate, or severe, advanced, and that would be according to the length of the implant and bone loss. So you have a guide so that you can make this notification. You know when to really send for peri-implantitis treatment as well. And then the one with no examination, of course, you're going to need to get radiographs at that time. Since you do not have them, you should look to the marginal bone loss. If it is 3 millimeters or more, then you should monitor this patient to see, to make sure that they don't have peri-implantitis, get a 3D scan if you can, to have a basis right when you see this new patient, to keep in your records. So, and they would be seen at least every 3 months and monitor them from there. So, Anne-Marie, do you have any comments on this as well?
Anne-Marie, I think you are muted.
I didn't want you to hear my coughing. Sorry. Because peri-implant mucositis, the main clinical characteristics is bleeding on probing. So it is important to probe. But also I support you, Susan, when you say that you have to put some pressure on the mucosa, because in my clinical experience, many times there could be a lot of pus deeper around the implant, and when you probe, there could be quite firm mucosa that hinder the probe to come into the lesion. And but when you palpate, there will come up like pus, like from a pimple, and I think that is important. However, I think we should a little bit take care when we have peri-implant health, because if it's health and we don't see any fractures or anything that could show any technical complication, maybe we don't need to take a radiograph every year. And CBCT is just, in my opinion, in special cases you need them. Otherwise, an intraoral radiograph is enough.
Okay, so yeah, this table is quite nice actually for chairside, when you just have to follow the clinical application and then classify each of the implants that you deem either as affected with mucositis or just healthy or with peri-implantitis. So it's quite like a clinical chart that could be useful, very useful at chairside. So with that, we have actually the assessment of the status of the implant and basically a diagnosis. But from that, what can we do to treat either mucositis or peri-implantitis, and what are exactly the non-surgical treatments? And Anne-Marie, I think I would like to have a go at that.
Yes, I would be happy to do so. So can we have the next slide? So what are the effective non-surgical treatments of peri-implant mucositis and mild peri-implantitis? And if you have in mind the radiographs I showed you of mild, moderate, and severe peri-implantitis from the radiographs, you can imagine how difficult it could be to manage non-surgical treatment from a professional way when you have the moderate and severe cases. So before starting taking your instrument in your hand, you must see the whole patient, and this is, of course, the most important thing is the patient able to cooperate with the oral hygiene, because you can be as good as you are. You can be the best to do non-surgical treatment with any instrument, but if the patient is not able to perform a proper daily oral plaque removal, then there will be no resolution of the inflammation. So, of course, the goal is to resolve the inflammation and achieve peri-implant health, and hereby prevent also future progressive bone loss. And with that, you start with the risk assessment. And we know from the World Workshop that the main risk factors are history of periodontitis and poor plaque control, and no regular maintenance or even lack of maintenance. But there were risk factors that there were inconclusive results on diabetes and also smoking. However, a recent study from 2020 have showed that smoking is a risk factor. And we know from the 40-year studies on periodontitis from Sri Lanka that onset of periodontitis starts with risk factors like calculus and smoking. So of course we can't transform all this perio field to the implant field, but smoking cessation is of course important. And when we examine the patient, we must check, of course, the general health, medications, uncontrolled diabetes. We must maybe consult a physician. As I told you about the smoking habits and visual signs of plaque. Is the patient able to perform a plaque control? And around the teeth, are there periodontal pathological pockets still there? We must, of course, treat them also. But when we assess the peri-implant tissues, we must and prosthesis, we must see if there are any loosened retention screws, are there any fractures, do the reconstruction, the prosthesis need a modification. Maybe we are not at all able to probe around the implant, and we may need to, in fact, remove it to be able to do a proper examination. And is there bleeding on probing? Is there pus? And do we need radiographs? And of course, cement excess. But now we know that there is bleeding on probing, but is there a lot of pus? That is a warning for me, at least, that this is more difficult than if there is only a small bleeding. But if we need a modification, it could be of the reconstruction, it could be a minor modification that you even can do as a dentist when the reconstruction is still fixed. However, it's easier to remove it. And if there needs to be a major modification, it may be considered to redesign and remake the reconstruction with the help of a technician. And then, of course, we must give the patient reinforcement of the oral hygiene. And I know you will come to that, Susan, later. But I think it's important to of course, if the patient doesn't have a proper oral hygiene, we can instruct. But also if the patients have a good oral hygiene, we must coach the patient and confirm the good habits. And the patient... Yeah.
May I just interrupt you, because there is a question about oral hygiene around implants. I'll just put it on screen here. The question is there more bleeding in sites with implants normally when toothbrushing, or same as non-implant sites?
That, in fact, I can't answer. Not in my clinical opinion. I know from studies that implants may bleed easier depending on if there are how the soft tissue is. But I can't answer that. Sorry, Susan. Maybe you are able to.
Well, I don't think it's the same. I don't think it's the same as a natural tooth. I don't think it's going to bleed as easily as you would see bleeding around a natural tooth. I think that to really check the bleeding around it, you have to kind of put the pressure on the tissue up on the ridge to be able to see that, generally speaking. If you do see bleeding easily when brushing around an implant, that's pretty serious. And I think I would make sure that if they were toothbrushing and there was bleeding around an implant, I think I would make sure and get that evaluated.
Thank you for both of your answers to this question. Sorry for the interruption, but you were talking about reinforcement of the oral hygiene.
And the patient's daily plaque control is of most importance, of course.
Yes.
But when we have checked this, and And then we go to our professional mechanical removal of calculus and biofilm. And as Susan, as you said, there are different tools, and we must of course use instrument that cause minimal alteration of the implant surface. And there are plastic, carbon fiber, and titanium curettes. And also we have ultrasonic instruments with different probes, and lasers, air polishing, and rotating brushes and cups. And the goal is, of course, to disrupt the biofilm and remove the calculus. And you can use whatever you want. There is no study that shows that any instrument is significant better than another. So that depends on what you have in your clinic and how you think that particular instrument can reach the implant surface, maybe in a deep pocket and there are exposed threads. And it is difficult. And sometimes you need to remove the reconstruction, the prosthesis, to get proper access to a deep pocket, even if there is not so much bone loss. And so you can use whatever you want with the goal to disrupt the biofilm and remove the calculus. However, if we look at adjunctive use of antiseptics, there are studies that show that adjunctives can have some effect, but there are no greater benefit than mechanical debridement alone. But in my opinion, some patients need adjunctive antiseptics, but not all. So if we look at what sort of antiseptics there are, we have, of course, the local antiseptics that are chlorhexidine, like solution or gels or even chips, but we also have local antibiotics. And then we have systemic antibiotics. And now we must take a little bit care because we have a threat with antibiotic resistance all over the world. And we as dentists, we must really be restrictive and use it when we really need. And if the patient have, let's say, mucositis, mild peri-implantitis as one implant, you can't prescribe systemic antibiotics. That is not professional at all. There are going to be a consensus in Madrid in November about treatment of peri-implantitis, and there will be a discussions about antibiotics, and we will see what the latest studies will show and how the consensus go. But take care. Of course, when you have done a non-surgical professional mechanical treatment around an implant or implants, you must do re-evaluation. And 1 month is recommended from the ITI, and taking in consideration that peri-implantitis develop faster than periodontitis and is more aggressive, it could be a recommendation to think about that to take a patient back to the clinic after around a month. Is there a resolution of the inflammation? Then the patient go to maintenance program with supportive therapy to see if it still is a stable, healthy mucosa around the implant, or if you have still some inflammation, but not so much, and even shallower pockets, but not a totally resolved inflammation, then you may need to do another non-surgical treatment, of course. However, if the probing pocket depth is 6 millimeter or more, with bleeding on probing, there is a risk of progression and a surgical approach may be considered. And yeah, Susan, what are your opinion of this?
Yes, I agree with you completely, Anne-Marie. And I do want to add one more thing that I think the studies that are coming out of, I think sure they're in Europe as well, but I'm most familiar with the ones from the University of Washington with Dr. Safatini and Dr. Georgios Kostakis, they are examining just chemical things like, mouth rinses and other things. And they are seeing some effect on the titanium oxide layer on the outside of implants. So I would like to just stress, to read on this and keep up to date on this, because it's important information as to what products, that you would use for this if you do see inflammation. In particular, we did a study on and noticed that if it was an extremely high fluoride with a low pH product was used, and they're trying to affect the inflammation and the gingivitis with that. If you see that, there is some good research now that may remove the titanium oxide layer off of an implant, make it prone to corrosion. So these are new studies. So this is just something to be aware of, to look at your non-surgical mouth rinses and treatments that you use, that you're conscious of that. It doesn't affect ceramic implants, but it does affect the oxide layer on the outside of titanium implants. And some mouth rinses, Dr. Giorgio Kostakis has done some recent research on that, and in particular chlorhexidine, glucamate, and things. So just stay aware of that.
Yeah.
Just because you wrote here mild peri-implantitis, it means then that for the moderates and the advanced peri-implantitis, you would recommend not just non-surgical, but also surgical, so probably flaps, but also regenerative treatments, right?
Yes, at first, all peri-implantitis cases must be treated in a non-surgical way to of course,
yes.
Get the patient to cooperate with the oral hygiene and get less in the peri-implant tissues. However, I think there is an ethical problem in a way when we have an elderly patient that have no dexterity for oral hygiene, and there is huge inflammation, infection, and pus. In those cases, I have tried an approach with surgery, in fact, directly, maybe to remove some implants, and but a strict maintenance program after, because we can't just leave it because the patient is not able or to cooperate. We must remove the inflammation and the infection and try to get the peri-implant tissues a new chance, but with a bad prognosis, in a way, adoptable prognosis, that the infection, of course, will come back. But that is only my own thoughts.
Okay, so yes, thanks for this precision. So basically, obviously, non-surgical treatments always starting with that whenever possible. But for moderate and advanced case, surgical treatments,
Yes.
be it whatever they are, needs to be considered to try to keep to take care, let's say, of the disease affected implants. Now that you have demonstrated that there are treatments to counteract the disease-affected implants. But of course, acting before the disease even happens is always best. And I believe that both of you put a focus, and a quite important focus, on prevention from the dentist perspective, but also obviously from the dental hygienist perspective. So maybe, Anne-Marie, may I start with you, with what you recommend the dentist's role is in prevention of peri-implant diseases in general?
Yes, and we have from the new ITI treatment guide recommendations of 3 different preventions. Like we have primary prevention, secondary prevention, and tertiary prevention. And primary prevention is, of course, when we want to achieve peri-implant health. And this is starts with 5 Ps: planning, preparation, placement, prosthesis, and prophylaxis. And going through all these 5, we start with the planning. And this is, of course, when we have decided that we are going to insert an implant or implants. And we do that because we want to place the implants in the most correct way, and also to do a proper prosthetic superstructure. And then we, of course, assess the bone volume. Is there a need for a regenerative surgery to get enough bone for the implant? And we also look at occlusal and mesiodistal space. Is there enough space for a single implant between those teeth? Or do we need to maybe have some orthodontic therapy before? And also we look into the soft tissue. Is there enough keratinized mucosa to prevent peri-implant disease in the future? And then we go over to the preparation, and that is preparation of both the patient in the way that we inform the patient of the risk factors, the risk indicators that may be. And that is, of course, could be medication, bisphosphonates, and could be also, of course, not a stable diabetes, and we need to get our patients that smoke cigarettes to stop smoking. And of course, treat periodontitis before we insert the implants. So we insert the implants in a healthy mouth. And then we go to the placement, and there we have, of course, we must do that in a proper way. We must handle the surgical field with care and take care of both the soft tissue and the bone, and not insert the implant too deep, too shallow, or too close to another implant or tooth, and follow the protocols. And of course, that is exactly the same when we go to the prosthesis. We must make the prosthesis that allow for assessment, probing, and also for the patient to be able to perform the daily plaque control. And if there is any consider about cement excess, you should have a screwed prosthesis. And at least I know in Scandinavia, we more or less recommend the prosthodontics screwed retentions. And then we have the prophylaxis. And as Susan said before, regular maintenance every 3 to 6 months. And to tell the patient that this is important, so the patient doesn't think that now I get my implants and my new crown or my prosthesis, and now everything is done. They must know from the beginning that they are going to be in a strict maintenance program, and that we assess and also try to control general health and risk indicators in the way we can, together with the physicians. And every time they come, it's like Susan said, and is going to talk about again, assessment of a superstructure. If there are loose abutments, loose occlusive screws, this could gain biofilm and lead to a peri-implant disease. And also to see if they're aware of the material and shipping. And this could be a sign of that we may have a bruxer and heavy heavy forces on the implant structure, and then recommend the patient a night guard. And always do periodontal and peri-implant assessment and control biofilm, motivation and re-instruction. And then, of course, professional biofilm and calculus removal. And as I see it, I think it was Armitage and Zanodi. I don't know if I pronounced the name right, Zanodi, but they, in one article, they said, put the patient to 0 plaque. And then, of course, there will be biofilm build up, but every time to do that as good as possible. And you will go into that, Susan, I know. So then secondary prevention is managing, of course, peri-implant mucositis and preventing onset of peri-implantitis. And then tertiary prevention is managing peri-implantitis and preventing implant loss. So do you have any comment, Susan, on that slide?
Not on that slide.
Yep. Yeah. Oh, good. I just want to comment a few things on this slide. This is a slide I usually use when I lecture. I see prevention also in 3 parts. We have prevention pre-implant therapy, we have prevention at implant therapy, and we have prevention of post-implant therapy. I think it's important to start prevention peri-implant disease before also, as the ITI guide said, that we insert the implants, because that is to have a good professional approach. And what I mean with that is that we want the best for the patient in a short and long term, and not what benefits your own needs. It could be money, but it could also be that it's very fun to insert implants. So we must have a proper risk assessment before and inform the patient. And to have a good professional approach may be to say no to the patient. Dental implants is not the best treatment option for you. And there are, as we know, other prosthetic solutions. However, if we say yes and we start the treatment planning, I can only support the ITI in that way, that we follow the protocols and we have the ITI SAC index that is simple, advanced, and complex cases, and that we do an optimal surgery and optimal prosthesis. And then we have the post implant therapy with the individual maintenance. And I will just, before Susan, you are going to talk about this individual maintenance. I just want to say a little short about not every patient need to have a fixed prosthesis. I think many elderly patients that have had their fixed restoration for many years need the dentist to say that now we are going to remake a reconstruction. We are going to make an overdenture. And an overdenture may be better for the patient in a way when they are not able to perform their oral hygiene themselves, and they need help from relatives or caregivers. So with that, Susan, I think you can go to what you are talking about from the dental hygienist's way.
The perspective, yes, Susan.
Yeah.
Yes, I think that it's really important, and I think the hygienists play an important role in the post-implant therapy, and they're the first responders, and they, I think they're stepping up to the plate, and they're really excited about this new level for them. But I think we really need to make hygienists aware to be able to detect any signs of inflammation around an implant. We also need them to monitor the patients, that they're making sure that they're coming in for their maintenance at least every 3 to 6 months. And the hygienists kind of stay on top of the patients with that as one of their roles, because this is so critical. Biofilm is our major risk factor, or one of the major risk factors for peri-implant disease. And I think it can't be taken seriously enough for the patients. And I really like the way Anne-Marie said to stress this at the beginning. Many patients think that now they have implants, they're no longer periodontal disease patients anymore, and oh, done, you know. So you have to really stress this from the beginning, that they are going to need maintenance. They're going to need even more care, and they're going to make sure they're going to need to do this biofilm removal on a serious, way for them to be able to do that and come in at least every 3 to 6 months. So when we walk through this, our role as hygienists in particular is to identify and really educate the patients on the fact that biofilm is a risk factor for your implant, that we need to identify it. We need to do what I like to say is professional biofilm removal with a subgingival air polisher, if possible, with glycine. If that's not possible, then a really good Prof paste that you polish first and remove that. If you don't have an air polisher, you can use maybe a Prof paste with xylitol in it and so forth, and really do a thorough polishing first. But we need to remove the oral biofilm professionally as equally as we do the calculus. So, and especially around implants. And so we need to work on that. We also need to remove the biofilm. And I talked about that a little bit. If you do possibly able to look into getting a subgingival air polisher with glycine, that is kind of researched out now to be one of the key tools that we could use around implants to remove the biofilm very effectively. But like I said, if you do not have that, polish real well with a good xylitol Prof paste to remove that. Maintenance, not all implants need to be debrided. A lot of them just need to have that biofilm removed. So always assess the implants to see if they need that. I have done extensive testing and published in my second textbook as well, all the latest studies on which tools and which instruments are designed to be safe and effective around implants. You can refer to that. I really am my own opinion, I'm very partial to the softer titanium implant scalers of 28 to 30 Rockwell hardness. They are titanium, they are like metals use, which is one of the guidelines. They're softer than implants, therefore they're going to be less likely to do any scratching, although we don't worry about scratching as much. It's more debris left behind on the implant surface, but it's good to have some safe, effective tools like that. You can also use your sonic or ultrasonic instruments as well. I just completed the latest studies on that, proving that we do not use plastic tips ultrasonically around implants, but we do have the thermal polymer resins like the PEEK tips, which are available on multiple different companies, have PEEK ultrasonic tips and the PEI tip on a magnestrictive. So you have options there that ultrasonically to use around implants. And then the most important one in my opinion, is the prevention, is the home care. And hygienists, you can really, really customize the home care for your patients. And I really emphasize this quite a bit because I think making sure that the patients are removing the biofilm effectively twice daily with the tools that they can use and they can access with, actually work with them and show them if they want to floss the implant, practice with them how to floss that. If they want to use a water flosser, how do we properly use that? Electric toothbrush or manual toothbrush. I'm also very fond of interdental brushes to disrupt and scrub around the implants. Often the interdental brushes are so good because they really can access the area that we really need to access wise around the implants. So I'm very, in my opinion, is very good to use around implants as well for home care. And I'm a strong believer that we do need a non-alcohol antimicrobial rinse twice daily if you can do that. And there are some safe CPC rinses and chlorine dioxide rinses and Vega rinses that work very well for that as well. But maintenance, I think, and a rubber tip stimulator, which I know was popular way long ago, but it's kind of, I always like to say, back in vogue, because a rubber tip stimulator around an implant is, I think, a golden idea, is my opinion, but at least once daily to really stimulate that gum tissue around the implants is extremely helpful, especially around a removable prosthesis with a bar that patients often have. And I agree with Anne-Marie. I would love to see the fact that, and I liked her opinion of changing the prosthetic from a fixed to a removable when they get to the point where they can't clean this themselves. I strongly agree with that. The removable ones, at least they can come off. Everybody can make sure everything looks excessively good, and then it can be properly cleaned. Are an excellent idea for patients. What we really need to make sure we do is that when a prosthesis is placed or an implant is placed, that it's placed with also maintenance in mind, maintenance and home care in mind. I would like to, strongly suggest that. And then, Andy, do you have any opinions on this as well? I think you might be muted.
That's because I cough now and then. So sorry. But I totally agree with you, Susan. And I think it's important to have in mind that it's very important to probe around the implants, but to probe gentle. Sometimes I think when I work as a consultant, there is an issue with the probing.
Right.
You probe too hard, and to know if you probe easy, gentle enough, is try to probe by your nail or under your nail. It shouldn't hurt, and so be aware of how you probe, but it's important to probe, and of course to in a professional way give oral hygiene instructions and have a good cooperation with your dentist, and as for me as dental hygienists, and even also of course the dental assistants. It's a team working around the patient and coaching the patients to have good oral hygiene habits.
Actually, we had a question, but I think that Susan, you answered to it. I will just show it so you can see. Are there any specific products, tools you recommend for implant maintenance and for home care? I think you covered that. So there is, I believe, another question. Yes, here. If the crown somehow is broken, does it hurt the implant? Is there any comment that you would like to do on this one?
Of course, if it's only a small, or what we call shipping of the porcelain or the material, we must take in mind that could hurt the implant if it's too much load on that crown or that bridge. It could be the first sign of that something is going to happen. And today I remove a lot of implants, more implants than I did 20 years ago, and even implants that are broken, just in the middle of the implant. It's broken, and then we understand it's a lot of forces that are needed to break an implant.
Yeah, I would like to comment on that too. I I think this only emphasizes the point that we place checking the occlusion. If it's only logical, really, if you're when does the patient get their occlusion checked regularly? It's usually after you've placed a new restoration or a new crown. But let's put it in the hygiene appointment, or the time that you're actually, maybe you do a once-a-year exam. You don't have a hygienist, but maybe you do a 6-month exam on your patients. At least every 6 months, check with a paper, indicating paper, and check the load. Check if they're catching on a side-to-side occlusion or anything. I think occlusion is really critical around an implant. And if something is chipped like this, or it's going to knock something off on that. So it can affect the implant if, like Anne-Marie said, if it does affect the load. So what's the best way to do that? And the simplest way is to put that in hands of, when you're doing the at least every 6 months maintenance, to have that as a part of your maintenance visit, that you check the occlusion.
Great, thank you for both of your answers. For the answers to the questions, we have arrived at the end of the session. Anne-Marie, Susan, you have some take-home messages for our audience. What can they take out of this session?
Well, first of all, I would say to you all, have a good professional approach. In a way, love your patients and want them all the best. And of course, as we have gone through, when you treat the patient with an implant or many implants, do an optimal therapy with a treatment planning, surgery, prosthesis, and a maintenance program. So you can prevent peri-implant diseases and diagnose early. And of course, risk assessment every time.
And I would like to just emphasize, which I've already emphasized in the program, but a professional in-office maintenance at least every 6 months, daily bile removal by the patient, and really stress this with the patients, of 80 to 85% of the biofilm every 8 to 12 hours is really important, and the overall success of the implants. And then just again, emphasize with the patients why the biofilm management is key. Also, biofilm left behind on implants is just possibly going to then affect their oral systemic health as well. So like Anne-Marie said, we are concerned with some of these elderly patients with this active infection around an implant. We can't let that go, so really educate patients and understand the care that they have around implants.
Thank you, Susan and Anne-Marie, for sharing your key points on oral care in implantology. It's time for us to close the session now. So Susan and Anne-Marie, thank you very much for being with us today. Sorry, something. Is it another question? Oh no, there is just a question that is still on, but we answered to it. Sorry. So yes, I was saying thank you for sharing your insights and your expertise on how home-based but also chair-side oral care can make the implant survive longer and better. I would like to also thank our audience for their attention. We hope you enjoyed the discussion and you could take some informative keys for your daily practice. This was the last webinar of this year. We hope to see you next year with new content, new programs. So make sure to stay tuned to be updated on what's next at Sunstar by subscribing to our YouTube and social media channels. But thank you all again very much for your company this year, and see you soon.
Thank you.
Bye. Thank you.